by acknowledging the Barngarla people, who are traditional custodians of the land on which we meet, and pay my respects to their elders past, present and emerging. I extend that respect to all Aboriginal and Torres Strait Islanders people in the audience here today. So thank you for Yvette for inviting me to speak to the ankylosing spondylitis support group today. I'm Ali Russell, I'm a physio with Air Sports Physiotherapy, and I am also a person with a diagnosis of ankylosing spondylitis. This will be more of a personal journey and my experience both as a patient and a therapist, less about facts and figures about the disease. But I hope that what it does is provoke some thought in the audience, and I'll share with you some of the learnings that I've had over the years that don't come from a textbook. So lived experience. But just to reiterate what actually is ankylosing spondylitis, and I'm sure many of you have already looked up the definitions and are familiar with it, but just to remind you, we call it an axial spondyloarthritis, which means it's an inflammatory arthritis that affects the spine. Now, they're talking now about two types. So your traditional ankylosing spondylitis, of which the nomenclature but I often talk about ankspond. So you'll hear me say ankspond rather than AS. And now a bit more information and research coming into this thing called non-radiographic axial spondyloarthritis, which is good because this is drawing in people that we were missing 20, 30 years ago on the diagnosis. Unfortunately, we are still missing them, but we're getting better at catching them. So, my story. For people who don't know, this is the township of Port Lincoln, and this was where I came in 1992 as a young, enthusiastic physiotherapy graduate. I'd done 4 years of hard slog and study, and I started, I've got a job in a private practice here in Port Lincoln. So I was very excited. I immersed myself in the town. I got back into my sport. I was playing netball, I was playing tennis, I was playing golf, I was even playing touch footy, which was a new one for me. But then about 15 months down the track, I started to feel really tired and run down. But I thought I was just going a bit hard and I needed a holiday, and I did have one coming up. So I thought, well, that's half of the course, I'll come good. But then I got a bladder infection, followed by conjunctivitis that same week, and then my hamstrings, both hamstrings went weirdly tight, and despite me stretching them, I couldn't get rid of that tightness. Then a week later, my right big toe just went red hot and swollen for no particular reason, and I started to get pain between my shoulder blades and down in my lumbo-pelvic region, which was all a bit weird. And I found, and this will be familiar to a lot of you, getting out of bed in the morning, I felt 85 years old. Mm-hmm. So at that time I was 23 and definitely not feeling my age in the mornings. I did keep working, but it took me, which again, familiar story, over an hour to get moving properly in the mornings. And if I stopped, I seized up and I was gone for all money. So I would keep working during the day, come home, collapse on the couch. I don't remember eating. I think I just came home and stopped. And one thing I do remember is I actually had to take analgesics to get going again. So if I wanted to get up and get ready to go to bed, brush my teeth, I actually had to take Panadol and wait the 20 minutes before I could get my body moving again. And then of course the night pain as we have. So being a physio, albeit a new one, I thought, well, I've got sports injuries, I've got musculoskeletal stuff going on. By that time, the bladder infection and the conjunctivitis had gone away. So I thought I would diagnose myself and treat myself. And I also had my holiday, and then I didn't get better. And what I learned later is there is this thing called the classic triad, which urethritis is like a lower level bladder or lower down in the bladder infection, conjunctivitis followed by arthritis. Now, this is now known to be more associated with what used to be called Reiter's syndrome, which is now called reactive arthritis. And reactive arthritis is typically more peripheral, so your feet and hands. However, it does have a bit of an axial component. So as you'll find overall, well, I was diagnosed with ankylosing spondylitis. I now wonder whether I had reactive arthritis or even a blend of the two. But like many things, the textbooks will say one thing and the patient presentation is a completely different thing. So I had pain everywhere. This was my representative body chart, those really tight hammies. I had right hip pain, I had knee pain, that was my swollen toe. I even had a sore shoulder, and of course this typical axial, which ended up being thoracic and lumbar spine sacroiliitis type symptoms. I started taking Nurofen, which helped, but I was struggling to make sense of my symptoms. They were weird and wonderful. And one thing I remember, welcome to the country, where I first lived in Port Lincoln, had an outside toilet. So you can imagine with ankh-spond and not being able to move in the middle of the night, having to go to the outside toilet. So I headed off out the back door, struggling to walk, so grabbed the broomstick on the way past, because when you're 23, you don't have a walking stick at home. So hobbled out to the toilet with my broomstick. My right hip was absolutely caning me. Did my business, hobbled back in. Just as I was about to reach the door, my right hip did this almighty crack and then suddenly felt perfect. And my right knee hurt. And me being a physio, I sat there and wriggled my right hip in all directions and could confirm that there was no pain emanating from my hip, but I suddenly couldn't walk on my right knee. So the take-home point from that was that if I'd had a patient who'd come in and told me that story at that point in my career, I would have thought they were nuts. So I was starting to question my own sanity. So was I losing my sanity? I was 23 years old, I had multiple varying areas of pain, I was stiff and sore getting out of bed, couldn't play my sport, and my symptoms were not improving. But I now know, well fortunately I had a doctor who believed me. Dear Dr. Mystery, I'll give him a shout out. Some in the audience may remember him. And when I went to him with my symptoms, he did not treat me like a hypochondriac, as I would have treated myself. Instead, he listened to my story and he said, I'm going to run some bloods on you, I'm going to send you for an x-ray, and we'll see what's going on. And my bloods, of course, the ESRs, the CRPs, the HLA-B27 that I'm sure the audience will be very familiar with, certainly did show up an indicator, although my x-ray was fine, which was good. So the diagnostic, or the suspected diagnosis was ankh-spond, and I was sent off to a rheumatologist, Dr. Robin Geddes in Adelaide, who did a bone scan, and my sacroiliac joints, as you have probably experienced in this audience, lit up like a Christmas tree. So fortunately from that, I got my diagnosis. So the good news is I wasn't crazy, but that came later with menopause and business ownership. So eventually I got my crazy. Now, it was great to have a diagnosis and have a target and something I could educate myself, but I did wonder, was this going to be my future? Because this was the picture I found in my textbook when I looked up ankylosing spondylitis and what it was. So the typical curvature, the bamboo spine, and I just completed 4 years of study as a physio, and I thought, has my career just gone before it's even started? So you can imagine that was pretty depressing for a 23-year-old at the time to think that this is what I'm facing. Fortunately, posture's not great, but not that bad. And I was also fortunate that over the years it never hit my hands, but during my working time when I had active arthritis, I spent most of my days on a thing called a saddle seat, a band-back saddle seat, which is actually literally a saddle on wheels. Great for hips because you can sit in like you're sitting on a horse. So you're not sitting in that 90-degree position. And I also wasn't on my feet all day. So I got quite good hamstrings, I think, at zooming around the clinic on this saddle seat. So now, this bone scan is not of me, but of course that's the classic look of sacroiliitis on a whole body bone scan. My bone scans were done in '93, there's no record of them. So I had to grab an image off the internet. But yeah, this is what I looked like. But I count myself very fortunate at the time to have had a good GP, a good rheumatologist, and I think I was actually lucky that I was young, because at 23 it was not right, obviously. But if I was 35 years old with 2 kids and I was complaining about being tired and run down and muscle pain, who's going to listen to me? If I was 45 years old, they're going to blame it on menopause or something. So in a way, my youth got me the diagnosis quicker, I think, than some of the other patients I've come across. Interestingly, back in my day, this was 30 years ago now, the incidence was quoted as 10 to 1 males to females. So I was also very lucky to be even considered as a potential AXPOND patient. I did note 10 years later, made me chuckle, it was being quoted as 5 to 1. I note now it is being quoted as 3 to 1. And in fact, Dr. Simon Burnett, who we spoke about earlier, a talk he did here in February 21, said 2 to 3 to 1 males to females. So I'm wondering if I'm going to live long enough to see it 1 to 1 and finally get that recognition that this is a disease that affects females as well as males. So hopefully I make it that far. Now, this is a case study I'm going to talk about, but I'm going to flag some half-time take-home messages. Number one, symptoms don't always make sense at the time. And I think anyone who's had ankylosing spondylitis for a while look back and think this is probably happening a lot earlier than when I presented to the doctors. Negative imaging doesn't mean a negative diagnosis. So my advice to the audience is don't feel fobbed off, or if you're hearing of people with similar symptoms, don't feel that it's not happening to them just because their imaging says nothing. The time to diagnosis, I note, continues to be a significant issue, especially for females, but hopefully that will continue to improve. And find people you trust, but also do your own research. And the Oceanside Health and Wellness website has some brilliant resources on it and some brilliant previous presentations, which I enjoyed watching. So great resource to get in there and learn about things. But here's just an example of what I now see in my practice, or what I've seen over the years. And this is a fairly typical story. So I'll start, it's a 38-year-old female. Now, she first presented to me in 2014 when she was 32 because she had a nerve entrapment in her right groin. Now, we think that was unrelated, and I was also asked to consult her on behalf of another physio in another practice because he couldn't work out what was going on. At the time, she did complain of lumbar pelvic pain, but she was walking so badly, I just put that down to her chronic gait pattern. So I helped with the diagnosis, I arranged surgery, that was successful, and then she went back to her treating physio. But she came back to me because this lumbar pelvic pain had persisted. And we would have expected it once she was walking much better after having the nerve released, we would have expected it to go away. So when she re-presented to me, which was May 2019, with this persistent spinal pain, she also had bilateral plantar fasciitis, which I thought is a bit weird. And she was also reporting morning stiffness. So hence my sad face, because my index of suspicion was going off. So I requested bloods, again, ESR, CRP, HLA-B27, added in an ANA from her GP. And that was not so easy. That took multiple letters, number of phone calls, even getting a little bit cranky. Can we please get this done? So in October 2020, after she'd had 2 MRIs, multiple blood tests, and 1 whole body bone scan later, and a rheumatologist visit that I had to fight pretty hard to get for her, she was given a diagnosis of undifferentiated inflammatory arthritis, but I would say it's a non-radiographic axial spondyloarthritis. Now here's the good news. The rheumatologist did put her on a methotrexate trial, the DMARD, and she improved. And she's now on Humira, which is a biologic medication, and she's been so much better since she's been on that. It's been a remarkable change in her symptoms. So time to diagnosis. Now remember, this is me picking her up with a suspicion that something's going on and me chasing her health professionals on her behalf. Yet it still took us 18 months. But you could question that it took her 6 years, because really she had symptoms of it way back when I first saw her in 2014. What I found interesting is 2 of her lumbar spine MRIs, well, in fact these are the only 2 she had, 2015 and 2020, completely normal, and this is actually her lumbar spine MRI, and it looks much better than mine even, and most of my patients. So trying to get her believed was quite a challenge when she kept throwing perfect imaging. And Lenny, one of my physios in the audience, will know that story with another of our patients who so, which is why I will keep pressing it. So the take-home message is, yeah, keep chasing, keep reporting symptoms, keep following through. Don't just give up if you really suspect something's happening there. Okay, now I'll talk about what makes me suspicious of something being ANC-SPOND versus osteoarthritis or chronic low back pain in a patient. But I do have to just flag that my experience in my early 20s was fortunately quite short-lived. Well, relatively short-lived for most people with ANC-SPOND. I had 2 years of pain. I don't know why, but I had a month off in between 12 months and then the next 12 months. You know, you never know what your body is doing or thinking at that particular time. Then it abated. One of the things I did do was change my job, and I suspect that the stress level reduction might have helped my symptoms. But I can tell you, giving birth 10 years later with stiff sacroiliac joints was not fun. So it came back to remind me then. So I feel quite fortunate that I didn't go on to a continuing course of ANC-SPOND, but I do think in my 2 years I felt enough pain and had enough symptoms that it's never left me how it feels to be like that. So when I see a patient come in with spinal pain associated with morning stiffness, but even persisting more than 10 to 15 minutes, because they'll say that it's, you know, spinal pain stiffness that lasts for an hour or 2 on rising, and that can certainly happen. But most of our chronic low back pains, once they're up and going, 15 minutes later, they're appreciably better. So when they're not, you start to have alarm bells ringing. Reports of seizing up after prolonged rest, because most of your mechanical low back pain patients and your osteoarthritic guys love to sit down and have a rest and have a hot pack, and then up they go and they're off and they're happy. But the ANC-SPOND guys, they're just worse. It's just harder to get up and get moving. I call it a semi-constant nature of pain. In my experience, the pain of those inflammatory arthritis patients will go up and down, but it's rarely nil. They just learn to manage with it. So it might not always be in their consciousness, or that, you know, if you ask them about it, they'll go, no, I don't have any pain. And then if they think about it, they go, well, yeah, I do. But the mechanical low back pain patients, you know, they'll have periods where they're fine, like it doesn't hurt, and then they'll do something and then it hurts. But the ANC-SPOND patients, it's just always there. And a big cue for me are these seemingly unrelated enthesopathies, which is where the tendon inserts into the bone and gets inflamed, which is a common picture with these sort of arthritis presentations. So like in my previous patient, the plantar fasciitis was, no, you shouldn't be getting that in your 30s, not bilaterally, not to the extent that you're getting it. So those sort of things will have me suspicious that something might be going on. Now, it can be frustrating for both me and the patient when the GP says, oh, it's just OA, it's just osteoarthritis, particularly when you get to your 40, 50-year-old patients that are presenting, but have probably not been diagnosed for many years. But I'd say it's even more frustrating when the rheumatologists get it wrong. So, which can happen, because they will sometimes rely on the imaging, not necessarily the bloods, and when you're not throwing something on the imaging, then you can't have ANC-SPOND. So I'm very much loving the literature coming out now on the non-radiographic ANC-SPOND, because as I said, it starts to cover those people that were always on the periphery and risk getting misdiagnosed. So as a physio, sometimes we need to be brave and sometimes we need to be crazy and just keep pushing through. But that is why this disease has such a long time to diagnosis. is people not being believed and females not being believed. But I won't get on my high horse about that. So I'm sure the audience all have stories of their own about their onset, and maybe there's some similarities with mine, maybe your story was completely different. But I find with every patient I've had, there's a story, there's a lead up, and the clues don't look as obvious in the beginning as they do in hindsight. So in my practice, I try and learn from the hindsight, so that the next person that comes along, I'm picking it up hopefully quicker than I did with the person before. But what can you do about it? Now, these are my top tips for management. I won't go into medication because there was a brilliant presentation on that earlier, and that's very individualised with your own medical team. But as a physio, the things I would say is pace yourself. So the old tortoise and hare. Boom and bust does not work with Angspond. I think people have found out. If you go too hard, you pay for it. It is much easier. Well, I can say this with 30 years more maturity than I had when I first got my diagnosis. But yeah, pacing yourself and doing things sensibly and not booming and busting, certainly recommended. Now the other one I say is make hay while the sun shines, and this is actually a picture from only a week ago of our paddock and my husband baling the hay and the sun came out. But when you feel good, you can do things, absolutely. And it concerns me that some people might feel good, but because of their condition and their fear of flaring things up, they won't get active or they won't exercise. So by all means, when you're feeling good, get out there and make hay while the sun shines. But be aware of also pacing yourself and not going hammer and tongs. Another thing I would add into this nowadays, I didn't have a picture of it, is mindfulness. Now, Karen Colwell, who was the chiropractor who did the talk, she mentioned mindfulness as being present in the moment and being grateful for what you have and positive thinking. I've also had the fortune of taking a mindfulness-based stress reduction course over a number of weeks, and what that taught me was be kind to yourself. Now, unfortunately, that came 20 years too late for me. But the point of the mindfulness of acknowledging your situation and not judging yourself, I think is, I wish I had known that 10 years earlier, because the life I had back then was different to the life I had planned. I had no idea what my future held. That had a lot of anxiety and concern. And sometimes I fought against it and I lost. So I think the mindfulness of just sitting back, taking stock, and I think of the serenity prayer, of having the serenity to accept the things you can't change, the courage to change the things you can, and ideally the wisdom to know the difference between the two. A lot easier said than done. And you know, I can stand here today with a relatively well-behaving body and preach this, but I definitely know what it was like to have your body do, I used to call it phase of the moon. Why was my pain increased? I don't know, phase of the moon. There was not always rhyme or reason. So what would I recommend people do if they either have a diagnosis of Angspond or have concerns that that might be what's going on in their body? Certainly educate themselves. So the Arthritis Australia site, there's a site now that was not around in my day called MYAS, which is My Angspond, which is an excellent resource. And of course, Oceanside Health and Wellness has brilliant resources, including some fantastic stretching videos from one of our physios, Lauren. Very well presented and easy to follow. So I highly recommend getting on there and having a look and trying them out. Ideally find medical professionals who listen. So your GPs, your physios, your rheumatologists, and if you're not being listened to, move. I have no qualms at all about saying that. If you're not being heard, find someone else, because your story is important and your clues are important, and you need someone who's listening well enough to put it all together and not to fob you off. Get appropriate medication. So those in the audience with the diagnosis are probably familiar with the DMARDs, the disease modifying anti-rheumatic drugs, and we now have the biologics coming out, and now we have biosimilar biologics coming out. That's getting ahead of me even. I'm concerned about the number of patients I will see who are taking a lot of anti-inflammatories and aren't on a DMARD. And my concern then is it's like the asthma analogy. So in asthma, you'll take Ventolin as a reliever, but to manage your asthma better, you will take a preventer. So a preventer is something that you take every day, and when you have flare-ups, you take your your Ventolin puffer to relieve it. That's my thinking with these inflammatory arthritises. If you have an ongoing problem, you should be taking your DMARD regularly and your anti-inflammatories for the breakthrough stuff. If you are pumping through a lot of anti-inflammatories and you're not taking a DMARD, to me that's an indicator that you're not managing your expond well, and you need to talk to your doctor about, well, ideally your rheumatologist, because they're the best place to prescribe your medication. But yeah, I'm not a pharmacist, but that is my experience of my patients and their medications, and how it works best. Where I am a sports physiotherapist, so this is where my strengths lie, and I'm definitely saying stay cardio fit, flexible, and sensibly strong. And what I mean by that is when you are cardio fit, and take it from someone who's not been cardio fit and then got cardio fit and then lost it again and oscillates between getting it back and not having it, life is always easier when you're cardio fit. So it's just easier to exist. So try and do some walking, try and do some swimming, try and do whatever you can to keep that baseline level of fitness up as best you can within the realms of your condition. Flexible, of course, this is a disease that is known to cause stiffness. As physios, we don't get fussed about people with thoracic kyphoses as long as that kyphotic curve is flexible. So if you've got the curve and you can get out of it, but you go back into it, that's fine. If you've got the curve and you're stuck in it, that's not so good. So flexibility is important to maintain, and that's again where those lovely 15 stretches from Lauren on the Oceanside Health and Wellness website can help. Just a word of caution, because I talked about not booming and busting. In the early days, I learned some exercises for my hip, and I thought that was so great. I did a lot of them, and then I didn't walk for a week. So again, learn to pace yourself. By all means stretch, but don't overdo it or you'll pay for it. And sensibly strong, there's a thing in our field we call stress shielding. It means that if you've got strong muscles around a joint, and for example an arthritic knee, the stronger you can get your quads, your hammies, your calves around your knee, the less stress your joint undergoes, because those muscles are helping support it. So in our sports medicine field, it's called stress shielding of the joint. So staying strong with a diagnosis of expond is important, but that has to be balanced with the fact that your propensity to get these enthesopathies, these insertional tendinitises of the Achilles, of the patellar tendon, of the glute tendons. So sensibly strong means not going to the gym and hammering out huge weights and massive reps. It means, again, pacing yourself, getting that strength but not overdoing it. Because when an enthesis gets annoyed, I don't know if anyone's had that in the past, so plantar fasciitis is a classic example of that. Life is not pleasant. As Karen alluded to in her talk, learn about the pain sciences. She spoke about the DIMS and the SIMS, called the dangers in me, the safety in me. Now that's work that's come out of this NOI group, which is proudly South Australian, and I'm fortunate enough that the leaders of the NOI group were my mentors and lecturers in my early physiotherapy days, and they continue to lecture to this day, and some of their information is what comes from this adipose tissue. We'll go on to that. But painrevolution.org is Lorimer Mosley's work, and a great site for getting to understand chronic pain and how to manage and how to live with it. So having chronic pain does not mean your life ends. It just means you need to get smarter at how you manage your life. As I've said before, learning about mindfulness also helps, and would certainly have helped me even more back in the day with my acute inflammation. Just want to touch on the latest research. So this is thanks to the NOI group who I did a webinar with them in May that ran over, 18 hours of work, I think over 2 weekends. But that took me a bit longer because I was stopping and rewinding. There's a lady called Tash Stanton who's well recognised in Adelaide as being a researcher in knee osteoarthritis. And what that group is finding, and not only her, many researchers across the world, adipose tissue, which sadly ladies is your fat tissue, has been shown to create inflammation. So if you've got an inflammatory condition, of course you want anti-inflammatory type medication, and you want to try and get a diet, as Karen said, that's low in inflammation, things that cause inflammation. But bear in mind that the more adipose tissue cells, the more fat cells you carry, unfortunately, the more your body is going to produce inflammation. Particularly for Tash in her osteoarthritis, we have a known factor that if you can reduce your body weight, you can reduce the pain of your knee arthritis. But what they're finding now is if your body weight is muscle mass versus your body weight is fat tissue, your pain is going to be higher when you're in the fat tissue group. So it's not just body weight, it's actually what sort of body you have. So if you've got more adipose tissue, you are going to get more inflammation. And I know it's so easy to say lose weight, and it's damn hard to do, especially after going past menopause. But do your best to keep your podgy bits down. So back to that cardio fitness. Have I got 5 more minutes to just explain a bit? I digress a little bit because this comes from the knee osteoarthritis research, but I think it helps tie in with pain sciences and understanding why your body might be doing what you're doing. So we have these things in our body called nociceptors, and they sit in the joints. And now we used to call them pain receptors, but we don't anymore because we know that they don't. Pain is interpreted in the brain. So it's the nociceptors, which they call them the danger receptors. They pick up the danger, they transmit it to the brain, and then the brain ascribes meaning to it. So the International Association for the Study of Pain's definition of pain is it is a sensory and emotional experience. So it's not just what you feel, it's your thoughts, your beliefs, your previous history, all ties in to create pain. But there's no denying these things called nociceptors are the things that send the messages up. Now, it's always nice when they're quiet because that means not messages coming up. The trouble with inflammation, and again, this research is done in the osteoarthritis field, I cannot say with clarity that it translates to the ANCSPON field, but I'd be pretty confident that we're going to find that relationship happening. So what we find is that the nociceptors in arthritis, in inflammatory arthritis, systemic arthritis of OA, which again is you could classify as ANCSPON, their sensitization goes up 69%, which means your little receptors that are recepting danger, and Tash Stanton talks about the accelerator, like putting your foot on the accelerator versus putting your foot on the brake. So these little things accelerate 69%. Now concurrently, there's a thing that comes down from your brain that we call descending inhibition. It's the body's way of filtering things out and saying, don't worry about that. So descending inhibition happens and we don't know anything, like we don't realize it's happening. That's sort of the calming effect, the don't stress about it effect. Tash calls it the brakes. So that descending inhibition in systemic arthritis has been shown to decrease by 20%, and in some people actually decrease by 50%. So it's a little bit complex, but what you've got is your nociceptors being sensitized 69-70%. So your accelerator is going up that far, your calming mechanisms being depressed 20 to 50%. So your body's really not helping. So it's a bit unfair, really. But this is to understand that no, it's not all in your head. Like your body and your inflammation is doing things to your metabolic homeostatic system that you can't necessarily control. But your best control comes from knowing about it, being educated, being on the right medications, having the right team, and keeping your body as healthy as you possibly can in that time. So thank you for indulging me of throwing in my pain sciences and that knowledge. But yeah, take home message, keep the tummy down the best you can. So thank you. And are there any questions? No, I'm always pleased because the physio I brought with me to answer the questions has had to go back to work. So this is us here, so Air Sports Physio. We're at Mortlock Clinic, which is Mortlock Terrace, Port Lincoln, South Australia. Lenny is a physio who fortunately got out of the questions. Lauren's our brilliant stretching exercise person. That's me, and we also have Nandini with us, who's a master's trained physio. And yeah, we're good at getting bodies moving again. So thank you, Yvette. Thank you, Axpon Group.